I am Dr. Salimullah, cardiologist from Saidu Group of Teaching Hospitals, Swat, and today's presenter for the topic Overview and Management of Tachy-arrhythmias and Brady arrhythmia in Various Clinical Conditions. Our speaker is Dr. Rashid Iqbal, who is Assistant Professor in Cardiology Department, Saidu Group of Teaching Hospitals. And our worthy panel of experts includes Professor Dr. Hafizur Rahman, Head Department of Cardiology, Saidu Group of Teaching Hospital, Associate Professor Dr. Abdul Hadi, Saidu Group of Teaching Hospital, and Assistant Professor Dr. Iftikhar Ahmed from Saidu Group of Teaching Hospital, Dr. Ilyas, Senior Registrar, Cardiology Department, Saidu Group of Teaching Hospital, and the rest of the two panelists who will join us later, Dr. Zahoor Ahmed, Associate Professor of Cardiology and Electrophysiology from Hayatabad Medical Complex, Peshawar, and Dr. Saeed Alam, Senior Registrar Cardiology, Saidu Group of Teaching Hospital. The course director of this cardio web series is Professor Dr. Syed Tahir Shah, and co-director is Assistant Professor Dr. Abdul Rauf. And all these activities are taking place under the supervisorships and mentorship of Professor Dr. Mahmood Al Hassan, who is the President of Pakistan Cardiac Society. So let's start our presentation. The presentation time will be from 25 to 30 minutes. And inshallah, after the presentation, we will take question and answer sessions. Over to Dr. Rashid.
Thank you, Dr. Salim. Today we will discuss arrhythmia overview and management of tachy-arrhythmias and Brady arrhythmias in various clinical conditions. So, first of all, in this presentation, we will discuss normal cardiac conduction system, cardiac arrhythmia mechanism, cardiac arrhythmia evaluation in clinical practice, cardiac arrhythmia general treatment concepts, guidelines for the management of Brady and tachy-arrhythmias, and arrhythmias in various clinical conditions. So impulse formation and impulse conduction occurs normally in conduction system of the heart. You all know that impulse initiation occurs in sinus node, and then it is conducted to the AV node, and then through the His-Purkinje system to the ventricular muscles. This is action potential in a ventricular muscle. It consists of 5 phases. The phase 0 is phase of depolarization. It is followed by early repolarization, plateau phase, late repolarization, and resting potential. All these phases are mediated by various ion channels and transporter proteins. Action potential is not same in all segments of the conduction system. There is variation in excitability, refractoriness, and conduction velocity in various components of the conduction system. Even in the ventricle, there is difference from epicardium to myocardium and endocardium. So this forms the molecular basis of various arrhythmias. The function of sinus node is regulated by the autonomic nervous system. A sympathetic activation causes a reduction in maximum diastolic potential, increases the steepness of phase 4 of action potential, and there is reduction in action potential duration, and as a result, automaticity of the sinus node is increased. Whereas parasympathetic nervous system causes increase in maximum diastolic potential, reduces the curve of phase 4 action potential, and increases action potential duration in sinus node, and thus reduces the automaticity of sinus node. Apart from sinus node, other components of the conduction system like AV node and Purkinje fibers are also capable of pacemaker activity at a lesser rate. Coming to the mechanism of various arrhythmias, Brady arrhythmia may be caused by decreased impulse formation or block in the normal conduction system. Whereas tachyarrhythmias may be caused by abnormal impulse formation or abnormal impulse conduction. Abnormal impulse formation may be either due to enhanced are abnormal automaticity are triggered activities in the form of early after depolarizations and delayed after depolarizations. Whereas abnormal conduction may be due to reentry, either due to functional, anatomical, or anisotropy properties of the cardiac conduction system. In this slide, you see there early after depolarizations and delayed after depolarizations. Early after depolarizations occur during phase 2 and 3 of the action potential, and this is responsible for various arrhythmias like torsade de pointes, whereas delayed after depolarizations occur in phase 4 of the action potential, and they may trigger arrhythmias in rhythmogenic right ventricular tachycardia, in cardiomyopathies, and CPVT. Here you see that usually delayed after depolarizations are of subthreshold level, but sometimes they reach the threshold for action potential and trigger arrhythmia. For reentry, we need two pathways with different refractory periods and conduction velocities. AV-NRT is an example of reentry into arrhythmia. Normally, impulse is conducted through the fast pathway and it is blocked in the slow pathway. But sometimes when the fast pathway is refractory, impulse conduction occurs through the slow pathway and it is blocked in the fast pathway. But at some occasions, impulse, when conducted through the slow pathway, it finds the fast pathway no longer refractory and it enters the fast pathway retrogradely, and thus an integrate slow pathway and retrograde fast pathway reentrant circuit is formed and arrhythmia is triggered. Clinical workup of arrhythmia, the most important investigation is ECG. This slide shows the importance of ECG in arrhythmia evaluation. Here you see a patient with sinus bradycardia, then atrial flutter, followed again by sinus Brady, persistent atrial flutter, then atrial flutter is terminated by prolonged sinus pause, junctional beats, and again sinus rhythm. So a single ECG strip is giving a lot of information about Brady and tachyarrhythmias. In another patient with suspected carotid sinus hypersensitivity, ECG was recorded while performing carotid sinus massage, and a prolonged sinus pause is documented. For arrhythmia which occur for paroxysmal arrhythmias, we are having cardiac arrhythmia monitoring system. For frequent arrhythmias, we perform Holter monitoring for if arrhythmia occurs 24 to 48 hours. For infrequent arrhythmias, we are having event recording system and loop recording system in the form of implantable and non-implantable devices. This patient was having dizzy spells and Holter monitor showed a significant sinus pause as a cause of the dizzy spell. Some arrhythmias are exercise-induced, so we perform exercise stress tests in those type of arrhythmias. Both Brady and tachyarrhythmias can be diagnosed with exercise stress tests. In this slide, you see that there is sinus node dysfunction and patient is chronotropically incompetent. Some arrhythmias like CPVT are triggered by exercise. So in evaluation of such arrhythmias, we do exercise stress test. EP study is used for diagnosis and in some cases treatment of arrhythmias. In this patient with sinus node disease, prolonged sinus node recovery time of 4.3 seconds is documented on EP study. This patient with broad complex tachycardia, when EP study was performed, there are more QRS complexes than A waves and ventricular tachycardia is diagnosed. For the diagnosis and treatment of AVRT, AV-NRT EP studies are used. So we will discuss Brady arrhythmias general management. So it consists of short-term treatment. We treat reversible or underlying cause of Brady arrhythmia. We give medications to increase heart rate, and temporary pacing is done. For long-term, we consider permanent pacemaker. And type of Brady arrhythmia, severity of symptoms, severity of underlying cardiac pathology, and severity of comorbid diseases are considered while making management decisions in Brady arrhythmias. Short-term treatment of tachy-arrhythmias consists of electrical therapy in unstable patients in the form of cardioversion or defibrillation, control of ventricular rate, and identification and treatment of reversible causes. Whereas long-term management consists of radiofrequency ablation, various antiarrhythmic drugs, anticoagulation, heart rhythm devices, and surgical treatment. And type of tachyarrhythmia, mechanism of tachyarrhythmia, underlying cardiovascular pathology, local expertise, and patient factors are considered while managing cardiac tachyarrhythmias. Now, some of the important guidelines. If a patient presents with acute bradycardia, the most important thing is to, after history and physical examination, is to assess for and treat reversible causes. When the patient is asymptomatic or having mild symptoms, patient should be evaluated and observed. For moderate to severe symptomatic bradycardia, we give atropine and look for any offending drug. If there are continued symptoms, then acute pacing is indicated. If there is persistent Brady arrhythmia and ECG is not diagnostic, we look for any exercise-related symptoms. So we do exercise ECG in such situations. If the symptoms are not exercise-related paroxysmal symptoms, we go for ambulatory ECG monitoring, and if the symptoms are infrequent, we go for implantable cardiac monitoring devices. In case of sinus node disease, if the symptoms are directly attributable to sinus node disease, or if the symptoms are caused by a drug which is a consequence of guidelines directed medical therapy and there is no alternative option available, so permanent pacing is indicated. In asymptomatic individuals are sleep-related sinus pauses, are in patients where symptoms do not correlate with the sinus node dysfunction, pacemaker is not indicated. In AV blocks, any symptomatic block is an indication for permanent pacemaker implantation. Complete heart block, advanced AV block, Mobitz type 2 heart block, or if there is evidence of infranodal block, permanent pacemaker is indicated. While deciding the type of permanent pacemaker, we consider risk of ventricular arrhythmias if the patient ejection fraction is less than 35%. So we consider biventricular pacing in the form of CRT. If the patient is having infrequent need for pacing and there are significant comorbidities, or there is atrial fibrillation, we implant a single chamber pacemaker. In other cases, dual chamber pacemaker is indicated. In case of bundle branch block or fascicular block with one-to-one conduction, if there is syncope, bundle branch block, and HV interval is more than 70 milliseconds on EP study, we implant permanent pacemaker. If there is alternating bundle branch block, this is another class 1 indication for permanent pacemaker. In other conditions with bundle branch block, we observe patient for need of any future pacemaker. Now, discussing tachyarrhythmias, first of all, sinus tachycardia is either physiological or inappropriate, for which there is no physiological explanation. In case of focal atrial tachyarrhythmias, long-term management is catheter ablation. For AV if the patient is symptomatic, slow pathway catheter ablation is indicated. Or if patient is not waiting for EP studies, we continue long-term beta blockers and calcium channel blockers. In case of accessory pathway, if there is pre-excitation and resting ECG, then long-term management is catheter ablation if the patient is willing. And if the pre-excitation is not present, then if the patient prefers ablation, we go for radiofrequency ablation, and we can continue beta blockers or rate-limiting calcium channel blockers in such patients. In atrial fibrillation, we consider various factors to decide the mode of the treatment strategy. If rate control is decided, then beta blockers or rate-limiting calcium channel blockers are given. In case of rhythm control strategy, catheter ablation is the treatment of choice. When there is sustained monomorphic VT, we look for hemodynamic stability. If the patient is unstable, we go for direct current cardioversion. In stable patients, 12-channel ECG, history and physical examinations, and echo is done. If there is underlying structural heart disease, electrical cardioversion, IV procainamide, and IV imidazole are the treatment options. If the ECG is typical for idiopathic ventricular arrhythmias, we give verapamil for verapamil sensitive VTs, and beta blockers are given for outflow tract VTs. In such cases, therapy to prevent recurrence of the arrhythmia, catheter ablation is class 1 indication in the long term. Now we will discuss arrhythmias in various clinical conditions. So you all know that acute coronary syndrome is in arrhythmogenic state. Both Brady and tachy-arrhythmias occur in ACS. The incidence of Brady arrhythmias is 0.3 to 18%, and both sinus node dysfunction or high degree AV blocks or bundle branch blocks can occur in acute coronary syndrome. So sinus node dysfunction most commonly occurs in infero-posterior wall MI. And if there is a patient is symptomatic with hypotension, dizziness, or pre-syncope, and there is no response to vagolytic therapy, then temporary pacemaker is indicated. Otherwise, we should observe patient. High degree AV blocks can either be caused by increased vagal tone or myocardial necrosis in the AV node or the surrounding tissue, and conduction abnormalities at the AV nodal level with second degree or worse AV conduction disturbances in acute MI stresses the importance of early reperfusion, preferably via percutaneous coronary intervention. So if patients are presenting with an acute MI, they are symptomatic and there is no response to medical therapy, temporary pacemaker is indicated, and permanent pacemaker is indicated after a waiting period if there is no gain of spontaneous sinus rhythm. In case of ventricular tachyarrhythmias, we divide these arrhythmias into monomorphic, polymorphic, and in some cases, tertiary dupont tachycardia can occur in acute coronary syndrome. So when the patient is hemodynamically unstable or has pulmonary edema, the tachycardia should be promptly cardioverted with a direct current synchronized shock. In patients with sustained hemodynamically stable monomorphic VTs, amiodarone is the drug of choice. Lidocaine, due to its ability to degenerate monomorphic VT into ventricular fibrillation, should be avoided in acute coronary syndrome. And the treatment of choice for polymorphic VT triggered by pauses or bradycardia is isoproterenol infusion, and atropine is an alternative to isoproterenol, which is not easily available. And in some cases, atrial or ventricular pacing will be needed to suppress polymorphic VT. In case of tertiary dupont tachycardia, IV magnesium sulfate may be efficacious even if the serum magnesium level is within the normal range. This is primary prevention for sudden cardiac death in patients with ischemic heart disease. So if the patient is more than 40 days post-MI or more than 90 days post-revascularization and still having NYHA 2-3 symptoms and ejection fraction is less than 35, ICD is class 1 indication. In cases with NYHA class 1 heart failure, if the ejection fraction is less than 30, still ICD is recommended. When a patient suffers a cardiac syncope, there is documented ventricular arrhythmias and ejection fraction is less than 35%, ICD is class 1 indication. In sudden cardiac arrest survivors or sustained spontaneous monomorphic VT, we look for ischemia warranting revascularization. If there is need for revascularization, we should go for it. Otherwise, we look for ICD candidacy, and if patient is candidate for ICD, then ICD should be implanted to prevent sudden cardiac death in these patients. Inherited arrhythmia syndromes are a group of genetic conditions that predispose seemingly healthy individuals to sudden cardiac arrest and death. Brugada syndrome, lung QT, ARVC, and CPVT are 4 of the most common causes of inherited arrhythmia syndromes. So if an arrhythmia rhythm is available and there is set the pointers on rhythm strip, it points towards lung QT syndrome, which may be either inherited or acquired. In case of polymorphic VT, we look for the initiating PVC. If it is short-coupled PVC, means it is within 400 milliseconds of the preceding QRS complex, then we are having differentials of short-coupled ventricular fibrillation, early repolarization syndrome, Brugada syndrome, and short QT syndromes. Whereas late-coupled PVCs point towards CPVT, late-coupled ventricular fibrillation, and cardiomyopathy. So in such cases, when patients present with acute arrhythmia and we are suspecting inherited arrhythmia disorders, we should first rule out ischemia and structural heart disease, and then we look for QT interval. If there is QT prolongation, then we look for either whether it is acquired or congenital and treat accordingly. For normal QT interval, we assess the coupling PVC. If PVC is short coupled, we give isoproterenol and quinidine for acute termination of the arrhythmia. And for late coupled PVCs, beta blockers and amiodarone, reducan, and procainamide are indicated. In heart failure, patients may develop a range of Brady arrhythmias, including sinus node dysfunction, various degrees of AV blocks, and ventricular conduction delay. So in patients with heart failure, the most common etiology of sinus node are Brady syndrome and ischemia. Acute therapy due to bradycardia aims at the prevention of acute heart failure in asystole. IV drugs like atropine, isoprenaline, or epinephrine, and transcutaneous or transvenous temporary pacing can be used during this acute management of Brady arrhythmias. And for long-term management of Brady arrhythmias, as you know that pacing the right ventricle can be deleterious, resulting in a relative delay in left ventricular activation and may induce ventricular asynchrony. So heart failure patients with pacemaker indication and expected high percentage of ventricular pacing, biventricular pacing appears the best choice. Atrial arrhythmias and congestive heart failure are closely related. While CHF promotes the development of atrial arrhythmias, in particular atrial fibrillation and flutter, the presence of these arrhythmias may exacerbate or cause left ventricular dysfunction and CHF. So if a patient with heart failure develops atrial fibrillation, first GDMT for heart failure and anticoagulation should be given. And then various factors like age, comorbidities, airtel size, these are considered, and a strategy for either rhythm control or rate control is devised. So for rhythm control, we are having pharmacological agents as well as atrial fibrillation ablation. For rate control, we can give pharmacological agents, and in refractory cases, AV nodal ablation and pacemaker implantations are indicated. Ventricular tachycardia is, you know that in heart failure, reduction in cardiac pumping efficiency leads to the activation of several compensatory mechanisms. And these mechanisms eventually lead to cardiac remodeling, fibrosis, and thus form a substrate for arrhythmia induction. There is increased automaticity, triggered activities, and reentry circuits in a failing heart. You can see in this slide that in heart failure, myocardial fibrosis remodeling provides substrate for arrhythmia induction, and arrhythmias in turn deteriorate the capacity of the heart. So ventricular arrhythmia should be managed with the treatment of the underlying cardiomyopathy, and ICD provides the best protection against sudden cardiac death from ventricular arrhythmias. Antiarrhythmic drugs and catheter ablation are important adjuncts for minimizing ICD shocks in recurrent ventricular arrhythmias. So if we implant ICD for primary or secondary prevention, patients can still experience sustained VT or VF episodes. So in such cases, we should evaluate and address the aggravating factors. We should optimize ICD programming, and we can either give antiarrhythmic drugs or catheter ablation can be done in such cases. So in summary, cardiac arrhythmias are caused by either abnormal impulse generation or impulse conduction. There are three mechanisms of arrhythmias: abnormal automaticity, triggered activity, and reentry. ECG, Holter monitoring, exercise ECG, and EP studies are used to evaluate various arrhythmias. And in cases of any Brady arrhythmia, we should assess and treat for reversible causes. Patients with acute coronary syndrome needs observation for arrhythmias and prompt treatment. Ventricular arrhythmia in a patient without structural or ischemic heart disease should raise suspicion for the presence of an underlying inherited heart rhythm disorder. And heart failure patients should receive GDMT and device therapy for primary prevention when indicated. Thank you.
Thank you so much, Dr. Rashid, for such an elaborative and well-explained presentation. So now I will ask my panel of experts to put their comments, views, or questions.
Can you hear me?
Yes, sir.
Yes, we are hearing you.
Thank you, Pakistan Cardio Society, for giving this opportunity, and Dr. Rashid for giving excellent talk. Although the topic was very lengthy, but you summarized very nicely and almost touched every aspect. My question is, if we have a patient with frequent PVCs, how to approach with patient with PVCs, and what is the risk of PVC-induced cardiomyopathy?
Sir, if the PVCs are very frequent, we do 24-hour Holter monitoring and quantify PVCs. So in studies, it is showed that if PVC burden is more than 20,000, then it can cause cardiomyopathy. But in generally, when patients with PVCs develop symptoms of heart failure, and the patient LV is on echocardiography, the LV function is deteriorating, then there is an indication for antiarrhythmic drugs. And if the patient is still not responsive, then radiofrequency ablation under 3D mapping is done.
So if the LV function is normal, what is the drug of choice? Which antiarrhythmic? If the LV function is normal, but patient has symptomatic frequent PVCs based upon 24-hour Holters, so which antiarrhythmic drug is best for this young patient?
Then we go for class 1C antiarrhythmic drugs if the LV is normal, like flecainide because these are having less adverse effects.
Mhm. And what is the
And for
outcome
that,
of frequency ablation? Success
Yeah.
rate of frequency ablation.
Radio frequency ablation, if done under 3D mapping, it is having excellent results. But in Pakistan, we are having the availability of 3D mapping is not that common. So while doing pace mapping, the success rate is little lower. So ideally, 3D mapping, PVC's ablation should be done under 3D mapping.
Thank you.
Thank you, sir.
Okay, Dr. Rashid, thank you so much for your nice and very nice and summarized presentation. My one question is, when the patient present with any Brady arrhythmia, and the underlying association is the acute coronary syndrome as well. So when we revascularize the patient, so for how long we can wait that the rhythm will come back to the sinus rhythm? Can you give some this timeline, or this is just a randomly assessment?
So in case of acute inferior wall MI, the heart block is most commonly due to vagal activation. So we can give a waiting period of 10 to 14 days to such patients. And in case of interior MIs, if the patient develops heart block, the treatment of choice is percutaneous coronary intervention. But if still patient is symptomatic, then we look for the waiting period is a little less. If after primary PCI, the patient is symptomatic. So in case of interior wall MIs, most commonly it is due to necrosis of the AV node. So permanent pacing is needed for such patients.
Hello, can you hear
Thank
me? Hello,
Yes, sir.
can you hear
Yes,
me?
we are hearing you.
Okay, good to see you after a long time, Dr. Rashid.
Yes, sir.
And it was an excellent talk and very comprehensive one, though it's a very, very, long topic just to cover all the arrhythmias, both the tachy-arrhythmias and the Brady arrhythmias in, half an hour. But can you please tell me how you will define the frequency, the frequency of the PVC? It's a frequent PVCs for ischemia and non-ischemia.
So various
Sorry to
properties.
interrupt. Sorry to interrupt you. Dr. Zahoor is with us. He was talking and asking a question. He is Associate Professor of Electrophysiology in Hyderabad Medical Complex. Now carry on with your answer.
Yes, Dr. Zaud Saab is an expert in PVC's evaluation, and he is having various talks on various forms on PVCs. So he will correct me. But most commonly, multifocal PVCs are associated with ischemias. And if there is a polymorphic VT in the setting of acute MIs, these are most probably due to ischemia. Monomorphic PVCs are which arise from a single focus are more associated with a scar or renal veins. So Dr. Zaud Saab will further guide us.
Okay, Rashid, most of the time what happens that, especially if you are sitting in your CCU at Swat and a patient presents to you with supraventricular tachycardia, right, with a documented SVT, and you have noticed that the sinus rhythm ECG earlier and the patient is having is in sinus rhythm, but now this time he or she is in tachycardia, and the patient is hemodynamically unstable. So how you will proceed in this case? What's your protocol?
Here, if as per guidelines, if the patient is hemodynamically unstable, we can give adenosine, which acts very fast, or if still the patient is having arrhythmia, we go for a DC cardioversion. It is a rule for any Brady arrhythmia. If the patient for any type of tachyarrhythmias, whether it is SVT or VT, if the patient is hemodynamically unstable, we go for DC cardioversion.
Actually, the message behind is the background behind is that why I'm going to ask this a simple question is that most of the patients who presents with the SVT and that is a documented SVT and with a hemodynamic instability with a BP of say just below 70 or 70 systolic or 80 systolic. So they, cardiovert straight away these patients. So my message is please don't cardiovert unless and until you do all the maneuvers like Salva maneuvers, right? IV adenosine. If that is not available, you can give a SOP10 or beta blocker. If, the patient is not reverted, then the last resort should be a DC cardioversion. So I have noticed that most of the patients, they are, cardioverted even with this documented SVT, and it should be discouraged. Now, one point, if that is not reverted with maneuvers, IV adenosine, IV beta blockers, calcium channel blockers, then the last resort that, should be a DC cardioversion or atrial overdrive pacing. Thank you.
Thank you, sir.
Dr. Zahoor, I
Can
have
I
a
have
question for you.
Dr. Zahoor? Can I have a question, Dr. Zahoor?
Sure.
Yes. Suppose if the patient is having unstable SVT with hypotension and the patient is not well, for how long one should wait before cardioversion? BP is, as per your statement, for example, BP is 70 millimeter of mercury. An unstable patient, for how long one should wait?
Yes, that's a good question. Actually, I have already told that whenever a patient is hemodynamically unstable and you notice that the patient is having BP of 80, say 80 or 70 systolic, just, do the maneuvers and give IV adenosine, just give one dose. If not, you can repeat the dose. And if, you notice that the patient is, going to deteriorate it, and there's the IV adenosine and the beta blocker, the pharmacological therapy is not going to work, then go and DC cardioversion. It depends on your decision and the stability of the patient, right? So the first step should be IV adenosine. If not, you can give, the second dose. If not, then go and DC cardioversion.
Yes, I'm also
There's no specific time just to, for how long you will stay and for how long, you have to wait and then go and cardioversion. But the thing is, this is my
risk. What is the risk of DC cardioversion early?
Sorry?
What is the risk of DC cardioversion earlier in the course of the treatment?
Basically, DC cardioversion, it's a very, very, alarming. It's very, very painful for the patient. That's why, I usually avoid these the DC cardioversion in these sort of, specifically in supraventricular tachycardia. And if the SVT is very, very incisive, like in case of antidromic AVRT or atrial tachycardia, especially the one which is coming from the left atrial appendage, which is considered to be the very incisive, tachycardia. So then you have to go for DC cardioversion. Otherwise, simple SVT, simple, if you think that this is a typical AV naughty or atypical AV naughty, most of the time it will revert with maneuvers and IV adenosine. One thing, the thing is how to approach a patient with tachyarrhythmia is very, very important. For example, say the patient presents with a narrow complex tachycardia, the definition of which is that the QRS complex should be less than 80 milliseconds, right? The first step is you have to look for the regularity, if it's regular or irregular. If it's regular, the next step you have to look for the visibility of the P waves. If the P waves is not visible, then straight away the diagnosis is a typical AV naughty. Right? If the P waves are visible, then look for whether the P waves are more than the V waves or not. If the P waves are more than, then the diagnosis could be atrial flutter, atrial tachycardia, things like that. The second step is the RP interval, right? And again, look for the, it's the short RP and the long RP. If the long RP, there are only 3 diagnoses, right? Atypical AV naughty, atrial tachycardia, AVRT, or PGRT, things like that. If not short RP tachycardia, this could be junctional tachycardia and typical AV naughty, and which are very, very well reverted with the, maneuvers and IV adenosine and beta blockers. So this approach should be followed. How to approach the patient with both for tachy-arrhythmias or for supraventricular tachycardia or ventricular tachycardia. This is very important. Being an electrophysiologist, sometimes even we can make a mistake. Oh, it's a VT, but not most of the time. Those patients who are having pre-existing bundle branch block, they may present with SVT. Right? But if you revert it and when you subject these patients to cardiac cath, then it is confirmed that it is SVT with a brain C or SVT with pre-existing bundle branch block. So approach is very important. And we have to, there are different approaches how to differentiate the SVT with aberrancy from the ventricular tachycardia, because both these patients present with a broad complex tachycardia. So ECG algorithm and the background knowledge is very, very important before subjecting these patients to cardiac cath, right? Another thing is, sorry.
Dr. Zahoor, it's always pleasure to hear you. One thing in cases of narrow complex regular tachycardia, sometime for the better evaluation of the P waves, sometime the literature says you can take extra leads in the form of Lewis leads. So how often you go for taking extra leads for the evaluation of P waves, and what do you think how much helpful they are in the better evaluation of P waves in case of narrow complex regular tachycardia?
For narrow complex tachycardia, especially if the P waves are not visible, then what we usually do, we increase the speed. Let's say the speed of the ECG is 25 millimeter, we make it 50 just to look for the P waves. Another thing is adenosine is very important, adenosine, because if you suspect that it could be atrial tachycardia or atrial flutter, then you monitor the patient, just give adenosine and look for the termination, right? If it is terminated with the A or it's terminated with the V, then it is very, very easily to assess the the nature of the tachycardia, which sort of tachycardia it is.
So in case, that was about giving the adenosine. What is the practice of taking some extra leads? Like sometime the literature says about the Lewis leads. They're putting some extra leads on the right side of the chest and just lower at the costal margin. So do you think is there any place of putting these extra leads, taking extra leads in this evaluation of the narrow complex regular tachycardia?
I don't think so. You can place the extra lead just to look for, the visibility of the P waves or just to confirm it. But it's very easy. I told you these maneuvers and that's it. I don't think so that we are going to do it ever in routine practice.
Assalamu alaikum.
Dr. Zahoor. Walaikum salam.
Zahoor bhai, very nicely elaborated, and Rashid, वो जो कहते हैं ना कि इसने दरिया को माशाल्लाह कुजी में बंद कर दिया है, तो very nicely presented. और महमूद साहब, क्या आप हमें सुन रहे हैं और आप हमारे साथ हैं कि नहीं?
5 minutes.
हेलो
सर का मुझे बता दे, मैं उसको अनम्यूट कर दूं।
महमूद साहब ने मैसेज किया था कि मैं ऑनलाइन हूं, तो मैं इसलिए उससे पूछ रहा हूं, प्रेसिडेंट पाकिस्तान कार्डियो सोसाइटी।
Sorry to interrupt, Rufai. I have a question, and first of all, I would like to have a comment on the presentation. It was very nicely presented, yet very elaborative and brief. The question is regarding atrial fibrillation. We most often receive patients with atrial fibrillation. There is often the first presentation or the cases paroxysmal AFib. So what we do is we go on and administer IV cordon. So the question is regarding whether we should offer antiarrhythmic at the time of presentation or just the rate control is enough. And regarding as per anticoagulation, we have to go for the Chartwell. So the question is regarding whether to go for anticoagulation or for rate control. And the second question is regarding the catheter ablation of paroxysmal AFib. So if a patient haven't used any antiarrhythmics, so will you recommend a patient to go for catheter ablation in paroxysmal AFib? Thank you.
So as far as management of acute AFib is concerned, if there is documented evidence the patient's symptoms are clear-cut less than 48 hours, we go for cardioversion, which may be in the form of IV amiodarone pharmacological drugs or electrical cardioversion. If the time period is undetermined, or if the AF is longer than 48 hours, then we go for anticoagulation for 4 weeks, regardless of Chadwick score, and then cardiovert the patient. And after that, for 3 weeks, another 3 weeks, we continue anticoagulation and then assess the patient for long need of anticoagulant drugs. Regarding catheter ablation of atrial fibrillation is concerned, first we should give class 1 or class 3 antiarrhythmics. And if the patient is still not responding to antiarrhythmic medications, then we go for catheter ablation. I would like Dr. Zahoor to further, if he is having any comment.
Well, it's a very, good question. The thing is, approach is very important. It's, for SVT or for VT or for FA patient over it, that Elias, whenever you come across with a patient with paroxysmal AFib, there is a definition of, AFib, whether it's a paroxysmal AFib, whether it's a persistent one, or whether it's a long-sustained, long-standing and persistent, whether it's a permanent one. These are very important. If the patient is having, permanent atrial fibrillation, and so there is no need, to do the DC cardioversion or chemical cardioversion. You have to control the heart rate, and that's it. If the patient is having a paroxysmal atrial fibrillation or a lone AFib, right, and you think that the echo is normal, and you determine the Chadwick score, and history is very important. Again, if the patient says that, oh, I have the damata start then this is very important, how to proceed for this patient. So whenever a patient presents less than 48 hours, straight away, and you determine the Chadwick score, this is very important. Again, the anticoagulation and then the chemical cardioversion or the the DC cardioversion. This could be the first step, right? And even if the patient is having persistent and long-standing, even then you can go for chemical cardioversion, the DC cardioversion, and anticoagulation. But for the permanent one, there is no need to go for cardioversion. It's a chemical cardioversion, a DC cardioversion. You have to control the heart rate. But for paroxysmal AFib, you have to straight away go and chemically cardioverted. It's, it depends on you. Most of the time, what I do, I straight away go and DC cardioversion, just sedate. But if the patient is having long-standing or persisting long-standing atrial fibrillation, P is very important. You have to exclude the left atrial appendage clot or the LA clot, and then you have to go proceed for, DC cardioversion. So this should be your approach, but it depends on a good history and examination. And then you have, but one thing, most of the time when we are sitting in a CCU, the TMOs are, so the big bore cannula, they should be in a big vein, not in a, small vein, because it causes phlebitis and things like that. So this is very important. Big vein, then go for IV cardio, right?
We are short of time. We should conclude by taking
just a minute. The question was a very practical one for our CCUs. This is the usual approach we all are talking about. What I'm asking is whether we should cardiovert every atrial fibrillation from the outset. The question is, we have seen the patients, they are reverting by spontaneously after 18 hours, say 24 hours. So if they are reverting and there is no risk, can we just leave them on heart rate control and say give time to nature for healing? And if the patient luckily reverse and we just save that, like Dr. Zohar said, a patient with SVT, if you offer early DC cardioversion per se carries a lot of risk. So keeping the same in recommendations for atrial fibrillation, a patient is relatively stable, he is not having any other risk factors. So why not to wait just for the heart rate control and proceed accordingly?
Actually, atrial fibrillation is it is not just rate control or symptoms control. We have to prevent thromboembolic complications of atrial fibrillation. So in young patients with paroxysmal AFib, it is better to go for a rhythm management strategy because it provides protection against thromboembolism as well.
Exactly, that makes sense now. That I got the point.
Assalamu alaikum.
Walaikum salam.
Walaikum salam.
Thank you so much for Pakistan Cardiac Society for a very good refresher on tachy-arrhythmias, although it was a very, very lengthy subject and there are books and books written on it. And Dr. Rashid did refresh our minds regarding Tachy and Brady arrhythmia. So it was really a good effort to enhance our knowledge regarding Tachy-arrhythmias and Brady arrhythmias. My question is regarding the placement of ICD in patients who are post-MI, ejection fraction less than 35, or they are in NEHA class 2 or 3. Don't you think that this ICD is overprescribed in these patients? Because in our setups, we see that almost 1/5 of our patient, even with primary revascularization, they end up having a low ejection fraction and they are symptomatic. So placing an ICD would save how many lives in these patients? And obviously it is not workable in our setups, but I wanted to know that is it really a good prescription for patients who are having ejection fraction of less than 35 and they are in NEHA class 2? Dr. Rashid.
So actually the most common cause of death in patients with cardiomyopathies is cardiac arrhythmias. So to prevent sudden cardiac death in these patients, in the absence of any reversible cause, ICD is the treatment of choice, and various studies have documented the benefits of ICD placement in such patients. But keeping in view our setup, where even essential antiarrhythmic drugs are not available. So it is although not practical, but still after 40 days of post-MI, when the ischemia cause, when the ischemic cause is no longer, then ICD should be placed.
How many lives it would save? How many lives it would save? Like, what is the number to treat?
Actually, various trials were conducted, like initially MEDIT, then MEDIT-2, and that showed a 30 to 40% reduction in mortality with ICDs, as I think.
Thank you so much. So we are about to the short of time. I think I request Professor Hafizur Rahman Sahab to conclude the session. And from behalf of Pakistan Cardiac Society, it was really, really very informative, very precise, and up to the mark. Not only the lecture, but the questions, more practical questions. I congratulate SWAT team for a very Saidu Teaching Hospital for a very nicely conducted session, and thanks Dr. Zahoor Saab for joining us and giving the valuable time. Professor Hafizur Rahman sir.
Thank you, Dr. Rauf. I request Dr. Abdul Hadi, being chapter coordinator of Pakistan Cardiac Society, SWAT chapter, for concluding remarks, please.
Okay, Professor Hafizur Rahman, transfer the responsibility. Thank you so much, Abdul Rauf, for coordination and making it possible this session. And indeed, the Pakistan Cardiac Society has taken very positive steps which have never been taken in the past. So I really congratulate the current council of Pakistan Cardiac Society for bringing very positive changes in their working style and involving the peripheral and the other chapters from all over the Pakistan, giving us a sense of ownership and belonging as well. So I really thankful to Rashid Iqbal Sahab, Dr. Salimullah for moderating this session, Dr. Ilyas, and no doubt indeed our team leader, Professor Dr. Hafizur Rahman, who is always motivating and helping us in arranging these activities. Once again, thank you, Abdul Rauf, for being in close coordination for making it possible. Thank you so much.